My name is Nick Thomas. I'm the clinical lead for research here at the Royal College of General Practitioners. And I have an amazing cast in front of you, an amazing panel standing here. And so, without further ado, I thought we'd get started, if that's all right. It's 10:15. Great to see you all. And I appreciate more people will be coming, and it's a very loud hubbub in the room behind. So hopefully you'll follow us. This is a great opportunity, and that's number one. It's an opportunity for practices, it's an opportunity for clinicians, and it's an opportunity for teams within practices to be involved in this and also really change the way that you might think about general practice and what you could bring to your community and bring to your practice. So that's why we're here, really. So hopefully stay with us, and we'll show you, we'll tell you why. Right, so first of all, the Research and Surveillance Centre. Has anybody heard of it, the RSC? Hands up if you have. Got a few, right, okay. Are you a member? That's the next question. Is your practice a member? No. One, that's right, two, three we've got. Okay. These are the plants, by the way. These are fixed. So sorry about that. All right. Okay, we're going to tell you why. So follow us again. Stick with us. By the end, you'll want to sign up. All right. So moving on, if that's okay. We've got a few the panel to go through. And so, as I said, I'm Nick Thomas. I'm a clinical lead for research here at the Royal College. And the Royal College works with Oxford, and we work together with UK HSA to really help support the Research and Surveillance Centre, which is an amazing entity, an amazing program and system and network, which is run by Professor Simon de Lusignan over here. We've got a few things to go through. We'll have a few speakers. So the plan is then for me to crack on, if that's all right, because time is limited. So I'll introduce Simon first, and there'll be a big Q&A at the end, if that's all right. So here we go, over to Simon.
Thanks very much, Nick. I'm just going to give a very quick overview of the Research and Surveillance Centre, and it's the national sentinel network. It spots flu, respiratory infections, and other monitored conditions. We're one of the oldest spotter networks in the world, and data collection started in 1957 and became formally the National Sentinel System in 1967, predominantly plotting out winter pressures and when flu would peak. And then virology sampling started in 1993, but only across the winter season. So virology would start end of October, run through to the end of March. And we'll come on to discuss how our clinical diagnostic nous in primary care has proved to be so important in this sentinel network. We're now in a situation where we do serology sampling, that's our vaccines working, what's natural immunity in the population all year round, and also all year round virology sampling, because there can be problems with viral illness all the year round. We've grown, as it says on the slide, from 100 to over 2,000 practices, and the ambition is to grow to over 50% of the population. Our current size is 23.5 million patients, and you can see from the map the dots of where our practices are, and we do near real-time reporting. Data recorded in primary care is anonymized and comes in for us to monitor rates of flu and things, usually within about 2 working days of recording. One of the really key things we record is influenza-like illness, or ILI. And I'm sure you all, how many here all put into their clinical system influenza-like illness in the winter, yeah? And of those ILI diagnoses we make, between 40 and 50% of them, if they have a virology swab, are positive for flu. And many of us as clinicians don't have that confidence in our clinical judgment that it represents a viral illness. Another sign that's very important in what we do is monitoring acute bronchitis and bronchiolitis in under 5-year-olds. And again, about 40% of those children who present will have RSV, which is now starting to be vaccinated against. So clinical data, virology, serology are the things we do, and there are opportunities for practices to get involved in the network. The pictures up on the top right of the slide are a guy, Ian Watson, known at the time as G.I. Watson, who was president of the College of GPs, but set up an infection centre in the 1950s in Surrey. Then there is my predecessor, Douglas Fleming, in the middle photograph, who ran the Sentinel Network from Birmingham. And then Maria Zambon, who joined UKHSA when it was Public Health England and started the virology service. Moving on, as I've said already, we collect pseudonymized data. What we're really interested in is looking at the numbers of acute respiratory infections that come in. And for all of you as GPs, if I can really urge you to get excited about recording what you think the diagnosis is, not cough as the problem, but if you think someone's got flu, influenza-like illness, if you think it's a lower respiratory infection, and we have as is top right on the slide, I want to ask where someone comes in with an acute respiratory infection, is it a flu-like illness? Is it an exacerbation of a chronic respiratory disease like asthma or COPD? Is it a lower respiratory? Is it an upper respiratory infection? And this is to try and classify risk. We collect virology samples from people with acute respiratory infections. And because there are now so many flu jabs, I think it's 6 different flu jabs offered this year, we're looking to collect about 1,000 samples a week through the winter season. And we do on some weeks exceed 1,000 samples a week, so that we can do a vaccine effectiveness analysis by the type of vaccine and the risk group, so the recommendations JCVI make are based on evidence for our population. I've talked about our virology sampling and our serology sampling, and we produce, and you can see the top of it, a weekly report from about 20 million people on what is circulating at the moment. Whizzing on to what's in it for participation practices, I've been delighted over my career, and I hope other practices are delighted to contribute to sentinel surveillance for its societal benefit and the impact it can have. In the pandemic and in outbreaks, we make fantastic contributions, picking up rare cases of flu that jump from animals to humans, but mainly around winter pressures. We pay our practices for providing samples, and our practice members who do virology find that the virology swab results are very, very useful for informing about antimicrobial stewardship. Oh, I saw kids who were wheezing last week. It came back as RSV. Your kid's wheezing. It's likely to be RSV or another virus, and you don't need an antibiotic. The research study opportunities, and we have this fantastic team to support. Down the bottom on the left is looking at the year in weeks along the bottom, where you can see the yellow peak. That is the peak of flu. And if you look, say, at the 2024 one, this one in the middle, you have the yellow peak of flu, and pre-flu, the grey one is always RSV that comes first, and the blue one that comes afterwards is HMPV, human metapneumovirus, for which there are already vaccines, and we may end up vaccinating for that at some time. The other graph at the bottom of the thing shows after first and second doses. The blue dots are COVID immunity after first dose of COVID vaccine, and the second graph, after the second dose and the persistence. And the serology our practices did in people who are immunocompromised showed a much more rapid rate in loss of immunity to COVID, and was absolutely pivotal in the short 6 months booster vaccines given in the pandemic. And these are the sort of things about which I get very excited, and I hope other people might too. Thank you for listening to me. I'm going to hand on to Gavin.
Thank you, Simon. I'm Gavin Jamie. I'm a GP. 3 days a week, working with the centre the other 2 days of the week. And actually, what we want is to get practices able to do research and able to do surveillance. Because not only is it interesting, not only can it be fun, it can also bring in some income to the practice as well, which is sometimes a bit easier than some of the other routes. I was trying to read the new contract letter last night, and I think this is probably the simpler option. So we want to become sort of research active in the practice, and that is very much a team game. So what we do at Oxford is we're taking some of the data from practice systems. So the first thing to do is to try and is to be able to sign up. So we have the data streaming in. This is all anonymous. So we take away patient identifiers. We are in many ways limited by what even getting down to the practice level. So we're not judging practices on there, but being able to sign up. It's a well-trodden path. There are over 2,000 practices who have done this already, and being able to do that, it does sometimes take a little bit of time just to get through the agreements if we need to go through governance and things that way. So please do come and sign up. It'll become part of our weekly report. You can meet us downstairs or catch us after this, and we can get things set up that way. Once you've done that, you're in a process of being able to do research, and as I say, it is very much a team game because you need to get different aspects of the practice all involved in this as well. It's definitely worth having an administrative contact because there may be payments coming in, there may be invoices and things coming out, so get them set up. Having a technical contact as well, particularly if you're involved in research projects, many of which are involved in setting up searches. We're sending out invitations to patients. That will all be done within the practice because we want to keep that patient data within the practice until the consents come in. The other things we're doing is sort of making sure, as Simon said, we're coding both when we're taking swabs and when we're doing procedures on patients. So we want to know what's going on because we only get the coded data in the end. There has to be a clinical lead as well, just to be able to review things, and they're probably going to be the main driver in the practice to get that through. But the whole practice needs to be involved. If patients have queries, they may be coming up to reception, they may be coming up to anywhere in the practice. So having that on there, having that awareness, having people knowing what's going on. And engage with the patients as well. If you've got a patient participation group, they are quite often fantastic at getting this out there. We have found there can be a real appetite amongst not every patient, but many patients for doing research, for doing surveillance. And so we're getting that through on there. I say we only get the coded data, so coded data quality does really matter. So Simon mentioned making sure we have a diagnosis for patients recorded. We're particularly interested in respiratory infections, but the more data we can get, the better. We're starting to look at doing things like being able to detect disease severity on the dashboards as well, being able to link symptoms on there. So having coded things for even just things like temperature, respiratory rate, oxygen saturation, that sort of thing as well. So really think about how you're managing things like QOF already, things that already need to be coded. So we'll have that procedure, you'll have the administration coming through. Of course, that's just getting it started, and being able to stay as sort of research active is more difficult because we need that sort of engagement on the practice. So we want to try and have as much motivation as possible, and that means visibility because we want, when people are seeing patients in the practice, we want to be thinking, is this patient eligible research? Has this patient got, when we're doing swabs, we're looking at patients with high temperatures, with cough over the last week, and that's the sort of thing we'll be looking for influenza-like illness, or we're looking for children who have wheeze or bronchitis. So we want to be quite aware of those. If we're doing more individual research projects, we do sometimes get a little bit more interventional. Then we want to be thinking about the sort of patients you want to recruit. And if that's at the top of your mind when you're doing it, and there are an awful lot of things competing to be at the top of your mind in practice at the moment, then we want to try and get that on there. We need to acknowledge people's effort. So having feedback to practices in meetings, through posters, anything like that, will help because people can see the visibility of what they're doing. And feeding back results to the staff doing the work, to the patients who we can send out individual results. And as a clinician, I find this incredibly powerful, that actually at the end of a consultation for a respiratory disease, we can say, this is probably a virus, but then take it slightly further and say, we want to find out which virus it is. Even if they're not interested in having a swab, we can look at the results and say, well, actually, what's circulating at the moment? I mean, at the end of last year, we were all talking about flu. We can be talking about RSV. For some reason, in Swindon at the moment, it is human metapneumovirus that we're getting 3 times out of 4 on our swabs, which is slightly unusual, and no one's heard of it, and people are interested in it. We also get the individual results back to the patients. Patients are really interested in what they have, and after all, it is them who are contributing data and have had a swab up their nose. So it seems only right that we're sort of feeding back to them because it is their data. We do publish results. Just this week, we have published some data on RSV incidents and things as well. So there are published papers. These are almost universally open access these days. So some patients will be interested in looking in that. And again, we can sort of plug that through. We plug it through our social media channels, but feel free to sort of plug it through yours as well. So again, we get that feedback. This is basically the graph that Simon was showing you earlier. Again, we can pin down exactly sort of which virus is going around. So this is on a slightly different scale, but you can see the yellow is the flu once again. And actually, we were able to split that down this year, so we knew the so-called super flu was largely an early flu epidemic. We saw epidemic flu just slightly earlier this year, and that actually settled down a bit earlier. The other thing is, if you're signed up, we will send you a weekly newsletter as well, so we can highlight some of these. We can support you in coding as well. I'm just going to wind this up. So we're looking at putting templates. So we're trying to make sure that when you're doing surveillance, you're entering the data just once. So we have, this is for TPP. We try to have a template which is your acute respiratory infections all on one template. We can get that through there. And that should be your consultation, but it is also the data that we need as well. So that we don't want duplicate entry. So we try to do that as much as possible, so we're harvesting the data. And the same comes through when the results come through in the end. So I'll wrap that up there. And so I was speaking a bit more of that at the end, and I'll pass on to Sophie.
Thank you very much. Cheers. I think I can use that one. Can you hear me okay? Can you hear me? Yeah? Hi. So my name's Sophie. I'm a GP and Professor of Primary Care and Clinical Education at the University of Oxford. And one of my roles is with the Royal College of General Practice, where I chair the Scientific Foundation Board. So I'm just going to take a couple of minutes just to showcase some of the ways that you can get involved with research through the college. And then if you're interested, please do come downstairs and have a chat with us. So as GPs in primary care, we use evidence and research in our practice all the time. And we might start to spot gaps in that evidence or need for new evidence. And we might even start to get excited about getting involved in the production of evidence. So you've already heard a couple of examples of ways to get involved in the production of evidence through your practice. Or you might also think about working with academic teams and production and leading of research in a variety of ways. So I'm just going to showcase a couple of the ways in which you can get involved in that. There we go. So we do a lot of capacity building activity to help people within practices to get involved in research. One of those is something called Research Ready, which is a quality assurance program where you can have access to training and research support and start to get the whole practice team involved in that research activity. We have something called a Research Engagement Hub, which is where you can start to learn more about academic primary care and related career paths. And we have a lot of partners with other organisations who are really active doing general practice and primary care research across the UK. So, for example, the Society of Academic Primary Care, SAPSI, and the NHR-funded School of Primary Care Research, and then the research, the RDN network that I think Nick will also talk about later. And then we have the Scientific Foundation Board, which I'll come on to talk a bit more about in a minute, that has a research paper of the year and awards grants that I'll tell you about how to get involved with. And then we have an annual conference, which you probably have perhaps been to, and we also connect with other academic primary care conferences that are happening throughout the year. So I'm just going to move on to tell you a couple of bits about the Scientific Foundation Board. We award nearly £100,000 per year now, and we award 3 of our larger annual grants, which are up to £30,000. And then we have practitioner allowance grants, or PAGs, which are smaller amounts of money, but if you're already employed but want to get some research off the ground, so for example, get some PPI involvement or some travel expenses for participants to get involved in research, you can apply for those. And then we also have a Research Paper of the Year award that we make each year, which is a really exciting way to celebrate some of the fantastic research that is happening. So this is just to show over the last 10 years. So we've just looked back from 2015 to 2025. And over that period of time, we've awarded 30 annual grants and 36 practitioner allowance grants. We've allocated now over £500,000 to support academic projects and career development for GPs, and all of those have disseminated their work in a variety of ways through publication. So Scientific Foundation Board work is often published at conferences such as the RCGP, but also SAPSI and School of Primary Care. And we publish, we encourage people who get the grants to publish in journals such as BJGP and others. So this is just to give you a flavour. We don't have one topic that we will fund. We have a big board that reviews all the applications, and I encourage you, if you're thinking about doing it, to come and ask and have a conversation about what you might want to get involved in. But just to get you a flavour, we've got projects we've funded on health inequalities, mental health, early diagnosis of cancer. We've had projects which are looking at core 20 plus population groups, such as Gypsy traveller Roma communities and their experiences of palliative care. We've funded quite a lot of work around workforce and workload in medical education. And there's no one method that we favour. We've had projects that use realist methodology, qualitative, quantitative, so a real variety of different projects. And then the PAGs, as I say, they're only £2,000, but actually the impact that a lot of this research has had has been huge. So examples here of projects around remote consulting and workload. And then if you go to our website, I've put the QR codes there, but if you go to our website, you can see some videos, and this is one that Dr. Nada Khan in Exeter did about her work, which the analysis showed the importance of job crafting in order to help us shape a sustainable GP workforce. So job crafting, getting involved in research, is one really nice opportunity of ways in which we can get extra enjoyment out of the work we do. So thank you very much for listening, and I'm going to hand over to Tracy.
Thank you. Hello, can you hear me okay? Can you hear me okay?
Yes.
Yeah? Okay. Hi, so my name's Tracy, and I'm a practice business manager at Magdalen Medical Practice, a practice in Norfolk in Norwich. We have about 15,000 patients. The clue is in the title, really, what I'm going to talk about, and that's the business side of research and what it means for us and what we can generate in practice, and why I think it's important that you get involved, and really just to keep it quite simple. So as a practice business manager, my kind of role I see is to help ease the burden off the doctors every day, so they haven't got to think about the business element. They can see the patients, care for the patients, and I can ensure that money's coming in and we're optimizing everything we can to make sure that patients are getting every service that we can possibly deliver and just ensure that really systems and infrastructures just work. So with that, obviously my involvement, I actually saw on one of the patient leaflets that the RCS sent out, and I saw that it said you can get paid to do this thing, and I thought, oh, what can we get paid for? So I had a look, and it was very simple. And research sometimes, sorry guys, I'm just being a little bit honest, can be a bit complex and a bit of a burden, and we can think, I really just don't want to get involved in this project. But actually, when I read through this, it was a no-brainer. So I basically looked at their details, spoke to the partners, got the team involved, thought about how we can set the program up in the practice, and just it's business as usual. We've been doing it now for years. We make a lot of money from it. It's really great. If you don't do it, you definitely should, which we'll come on to in a bit. So I guess really we talk about the serology and virology sampling. So the staff that we get involved in that actually is mostly just the healthcare assistants. So, you know, we don't need to use any of our highly paid resources. We kind of look at what can make their job more enjoyable as well, so we don't have to just, you know, do the same thing every day. They can get involved in research and they're loving it. They are seeing patients. So if the doctors, one example is, if the doctors see a patient and they feel like they've got a respiratory condition, they'll send them to the healthcare assistant or to reception and ask for a swab, and then they'll support the patient, do the swab, and the patient will wait for their results, and it's done. It's really quick and simple. Patient goes away, the doctor hasn't prescribed anything yet, we're waiting on the results, we get paid to do that, so it's really quick. The other thing we also do, which has been the bonus this year, which was introduced, is the self-swabbing. So now we get our patients to actually just take away the kits as well. They can scan a QR code. We pop it on our Facebook page. We promote it all the time. And so we just say, if you feel unwell or you think you've got a respiratory condition, just get a kit. Come in, get a kit from us, swab, you know, come and have a swab. They do that and we get paid for it. So it's great when they get their results. So when the results come back, we obviously call the patients and we let them know, yes, you did have flu or you did have RSV, etc. And then we can code it correctly. We pass that information to the GPs and they can code what the condition was or not. And the patients, as my colleague said, are really pleased to actually have not just it's viral, that actually can have a result from the outcome of the swab. So that's really good. I mean, in terms of obviously the accurate claims, obviously, you can imagine my role is make sure you code properly, make sure we're getting as many patients to have the swabs or the blood tests, whatever. I think really what's interesting as well is with, say, for example, the blood tests, they're coming in for a blood test anyway. And so all of our healthcare assistants are doing is saying to the patient, would you mind if we just take an extra sample as part of the research? And often they just, yes, no problem at all. So we take those, send them off, and we get paid for it. So it's really, again, so simple. So really, our clinicians don't get involved too much. They make sure they code properly once we get the results back, or they make sure that they're aware to send all their patients straight to reception to pick a kit up. And that's it, really. It's more administrative support that we do. I've talked really about the healthcare assistants, the nurses, the admin teams, all of the people that's involved in this. Obviously, in terms of the kudos, what it brings to the practice is, again, we can promote that we do research, and it's really not onerous research. It's great. We can kind of say, oh, we're heavily involved in this. We've had hundreds and hundreds of patients, so we've made quite a bit of income from it, and at the same time we're contributing to the scientists and the more important people that I'm not kind of thinking of when I'm just thinking of the money, that their results that they're getting and influencing the change in the trends and all of the things that they need to do to keep everybody safe. So yeah, so that's kind of my element of it. I am very, savvy around looking at when the results come back to make sure that they're all documented, to make sure that our invoices have gone in, to make sure we've been paid for the work we've done. So again, that doesn't take too long because you just keep good records. But really, yeah, it's just a really, I'm a real advocate for RCS. It's such a nice, simple research project that you can do in your practice, and patients really appreciate it. They feel like they're not just being sent out of the doctor's door, they're gonna get a swab on their way out. For some reason, they really enjoy that. But anyway, that's, really, it's really helpful to everybody. And, we have a diverse population at the practice. So again, those patients as well with the communication barriers, it's very simple. We can support them through it. They can see what it is. There's clear instructions. So we're getting a mixed range of swabs as well when we're doing those. So really, that's everything. Just the key message from me is, like I say, it is a simple research project to get involved in. If you're not, please do. You can speak and ask anything about the money and the processes that we have in practice, which is basically to streamline and use the resources that you've got to keep it as cost effective as possible and make as much money as you can from that as well. So thank you.
Morning, everyone. Can you hear me all right? Yep, perfect. My name is Vanashree Sexton. I work as a researcher in the Research and Surveillance Centre. I recently moved from the practice liaison team as well, so I'm very used to supporting practices on our studies. So in the next 5 minutes, I'll give you an overview of the types of research that we run at the RSC, just to give you a flavour of the types of work that you could get involved in. So I'll start by taking you through 3 of our really key recent studies. The first one was observatory, and this was a really exciting project looking at point of care testing. We recruited 21 practices across England to take part in this, and we provided participating practices with a point of care testing device. So this was great, as when patients came in with a respiratory infection, practices could simply ask them for a swab, and then they could test the swab within the point of care testing device at the practice and get a result within half an hour. So we had really great feedback from practices that took part in this study. The next study I wanted to highlight is the IID3 study. This is the 3rd study of infectious intestinal disease in the UK. This was funded by the Food Standards Agency. So this was one of our kind of larger scale studies. We had about 170 practices taking part in it, and we recruited around 10,000 participants through the practices that took part. So this was really quite light touch for practices. So it involved recruiting patients who reported their symptoms of vomiting or diarrhea on a weekly basis for a 1-year period. I say it's light touch because this was all conducted through a mobile app, and even the consent was conducted by patients themselves, so there was not really practice involvement in the consent side of it. So this allowed us to look at patterns of pathogens that are circulating in the population, and also in the types of bugs that patients are coming to when they come into practice with this type of intestinal infectious disease symptoms. The 3rd study to highlight was a slightly different design, so it was a cluster randomized trial investigating deprescribing behaviours. And for this study, half of the practices were randomized to receive an intervention, which was like an online module, a training module. And this was really designed to minimize risk in patients who have multimorbidity. This study was run at 50 practices across England. So those are some of the key kind of projects that we've run recently. There are also opportunities to take part in our surveillance work, as Tracy has mentioned already, and we're actively recruiting for any practices that would like to take part in our virology sampling. There are a couple of different pathways that are currently open to recruitment, so please come and visit our stand. We're on J31. We're really happy to sign you up or answer any of your questions. So we continue to develop research projects. Every year we have new projects, and typically the winter season is when we have kind of the busiest time, when we have different research studies running. We're currently designing a new household-based points of care testing study, just to give you an idea of kind of upcoming projects. And I think Gavin already mentioned that if you're part of the network, you'll receive newsletters, and these contain opportunities about the different projects you can get involved in. So if you're not already part of the network, there's a QR code here which will take you directly to our sign-up form. And once you've signed up, a practice liaison officer will be in touch with you and help you to sign up, and it is a really quick process. So we also have opportunities for collaboration, and we'd really like to hear from you if you're passionate about a particular area and would like to work with us to design your research. And this would help you to also make use of the resources that we have at the RSC, including the primary care data and practice liaison team as well. So the final slide is around patient and public involvement and engagement. So this is a really key part of what we do as well. And if you're part of the network, there are lots of opportunities for your patients to get involved in feeding into the design of our projects. And we will typically ask if you can help us advertise some of these opportunities on your social media or through your PPG groups. We also, quite recently, are extending this to also include practice staff in some of this feedback as well through our professional engagement network. So if you'd like to get involved in that, there's also a QR code here. Thanks so much. I'll leave this on so you can use the QR code, and I'll hand back over to Nick.
Thanks, everybody. That was really informative. It was excellent to hear. Hopefully you all saw it was a real showcase in what is out there for you as a practice, how we can support you. I think that's really important. Sophie showed us an amazing slide really about what the RCGP research program is all about. So many different elements of research, right the way through from academic development, right the way through to research delivery and how to get your practice involved and how you can personally become involved. Really, 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 really key to this. Questions, first of all, from the audience. Any thoughts, any burning ideas? Just a quick comment from me as well. If you think about what Simon said, over 2,000 member practices already, so 1 in 3 in England are members of the RSC. So does that mean there's a third of you in the room are already members who don't know about it yet? And your practice manager's already done it for you? Is that possible? Don't know. A few people are laughing here thinking, oh, maybe it's right. It possibly might be. If it's not, then where have you been? Because as Tracy said, it's a bit of a no-brainer. Right. Any thoughts? Any questions? I've got a few things. No? Okay. I'll go straight to Tracy first of all, if that's all right, because I want to know how easy it was to sign up. But she said she's wanting a leaflet. I think that's a really key. What do I do next? I see it in a leaflet. I see it here. What do I do now?
So it is very simple to sign up. I mean, I just saw, as we do, get lots of leaflets come through and lots of emails. So I was just reading through, and I saw a little link that said you can make money from this research project and how helpful it was going to be. And there was a little email on there just to message the RSC, just to contact them and say, I'm interested and signed up. And that was simple. I sent one email and said, I'm interested and signed up, and then had a quick meeting, and it was done. And it was as simple as that. So just email the team. I think the QR code and the guys at the stand will be able to help as well. But like I say, in terms of what we do in practice for it and the processes, you're welcome to contact me as well, and I can sort of share what we do as a process just to make sure that you guys keep it as simple as you can as well. But yeah, very easy to sign up.
Okay, great. Thanks very much. Yep, so you get your PLO team, so one of our Ash's colleagues will come and have a chat with you, take you through it, hold your hand. Very, very simple. My practice is signed up, of course it is. Influenza result came through to me this morning. Works really well. So I know that influenza is circulating in my community in West Oxfordshire at the moment. Gavin said it's human metapneumovirus there in Swindon. It just shows Oxford and Swindon aren't very far apart, but it's really good to know what's circulating in your area right now, so you know what you're seeing and that, at the clinical coalface. So that's really, really key, and that's why it's so important. Because of course, did we dish out amoxicillin to that patient with their influenza? No, we didn't. We've confirmed they've got influenza. Therefore, we can re-educate not just us, our team, but also the patient as well. And then for next time, that's really, really key, because how else are we going to try and protect ourselves for the future? It's by doing this. Really, really important. As Simon showed us with all the different surveillance work that can be done, not just the virology, but the serology work as well. There's multiple opportunities. Right, we have a question from the floor. Sorry. Hello? Yeah. So, there's a question here, sorry. They're going to run down. While we're waiting for the microphone, just mentioning we've got a stand downstairs. The stand's at J30, all right? So please feel free, if you don't want to click on the button on the QR code, just come and have a chat. There's a bunch of us who are going to be there. Really not a problem. Right, sorry.
Thank you very much. Great talk. I was wondering, thinking a little bit ahead to getting this registration of all these sort of information into the quality outcome framework and basic GP funding in the long term, have you got any evidence that the 2,000 practices signed up prescribe significantly less antibiotics than other practices overall?
I'll take this to Simon. I'll pass that through. Yes.
Yeah, I think I'm wired up. The question, if people didn't hear it, was, is there any evidence base that quality is better? Obviously, the answer must be yes, because I'm completely unbiased. But if I try and be more scientific, I think there are two strands of argument. One of my sayings I missed out of in my talk was coding is caring. It's very difficult to analyze quality without high quality data, and coding the presenting problem is probably the most important, and having a medical record that the next clinician can understand your clinical logic. For that, I need a grant from Sophie to test. But where we do see benefit, and we've seen it particularly where we've done point of care testing, is where we have practices involved in studies where virology results are available. It's very positively associated with lower antimicrobial therapy. It is an association, not causation. And I think as public attitudes have changed. Prior to the pandemic, about 5% of people, I gag with a swab, I won't have one. The population's swabbable, but want to know what the disease is and are reassured by virology results.
Great, thank you, Simon. The comment to make really is thinking about vaccine effectiveness as well. Simon's mentioned that already. The serology work that the RSC does, absolutely amazing in really working out how effective the vaccines are, what's happening for next year, helping to inform you, KHSA going forward. It's really, really key. We've got a question from the audience, sorry. Thank you.
Thanks, Nick. I'm Karina. I'm part of the Research and Surveillance Centre team. So I just wanted to let you all know our UKHSA Commission Surveillance Service, we have just agreed our targets for 2026-27. We have lots of capacity for new practices to join our virology sampling. We've got an in-practice pathway and the patient self-swabbing pathway on offer. £12.50 per valid sample. It's all year round swabbing. Would love to get you onboarded in the spring and summer, and so that we can scale up for winter. But there's lots on offer. If you're part of the network, then you are able to engage in research studies opportunities as well, which are always funded for practice time. And it's a wonderful offer around professional development for your colleagues in terms of being involved with research and being research active. And don't forget, RCGP's got a wonderful digital research-ready training offer. We can talk to you that as well. But I've got pamphlets I can give out at the end of this, so please come and see us at the stand. Thanks.
Great, thank you. We've got time for one quick question, and one more if we hear the gentleman here, but I've got 2 minutes left, I think, so we're going to go really quick. Thank you for that, Karina.
I was just wondering, with the swabbing, does that encourage people to come in? Because obviously we're all drowning in patients with their minor illness, and we don't really want to encourage people to attend with the self-limiting illness. And if we're promoting swabbing, does that promote attendance for a self-limiting illness?
Great question. Absolutely. Not in my experience, in my practice, no. In fact, it's re-informing and re-educating is really what it's doing, making sure that you are in the self-limiting illnesses able to self-manage and then understand that next time I don't need a pitch up to my GP for my amoxicillin, thanks very much, and why haven't you given it to me yet? I think is ultimately what sometimes a message you get to the cold face, and we get that quite a lot. And so I think the panel agree with that one. Yep, that's pretty quite an easy one from our side. Right, without further ado, I think I've got to bring this to a close, and thank you very much. So first of all, I'd like to thank our speakers for a really informative time, giving up their time today. Absolutely fantastic. So thank you, first of all. Secondly, I'd like to thank Best Practice for hosting us today. So really a great opportunity for us to really showcase what the power of primary care can be with the RSC. Really, really important on behalf of the Royal College of GPs. I'd like to thank them for that. I'd like to thank yourselves, of course, for coming and listening to us and spending time, giving up your 45 minutes of your day today with us. And I appreciate that's really important. But actually, it's a great opportunity for your practice to get involved. It's a bit of a no-brainer. 1 in 3 of you probably already are. You just don't know it yet. I think that's another thought about this one. And then finally, really, if Tracy wasn't here, then actually, as a practice manager kind of side of things, that's why she's here, is because it must work for the practice as well in a number of ways, not just the holistic, the surveillance, the disease protection and everything else that we know it obviously does. And so I'd like to thank you all. I wish you the best of the rest of your day, and hopefully it goes well. Take care.